My daughter-in-law had complete knee replacement.
Oh, wow.
So she's down in Ecumen now. Place
In-
on
London Road?
Yeah.
Yeah.
She went there yesterday.
Yeah, that's a great facility.
Because the doctor said, your physical therapist will not be kind to you. You will think that she's not kind to you because of the exercises that you have to do.
right.
But she was doing pretty good, actually. Friday I stopped in after Alexandria. She had over with the surgery at 12:30. I came about 4:30, and she was sitting up in a chair and kind of moving her leg a little bit. Of course, she was under heavy sedation, but, you know,
Yeah,
a couple
Yeah.
pain pills, but
yeah.
at least she could move it without screaming.
Oh, my gosh, yeah. Just sounds so
Just the
amazing.
sound of it is like, whoa.
Yeah.
I'll stop and see her tomorrow.
Show you how to move.
Yeah,
it, and
yeah.
then go
For my
home and do
meetings.
it.
Oh, so you, and then you're just going
I
to stay
stay
down?
over, I stay over with
Oh, okay.
Steph, and,
Yeah.
So that's kind
And then you're going to stay through the Virginia meeting too, or you'll come back? and
No,
go
I
back?
have, well, I have to be back here for the WTIP.
Oh, of course you do. Yeah, don't forget.
And we're
Yeah.
going to the county historical dinner too.
Oh, nice.
Push the button,
St.
Anita.
John's.
Swelling probably went down.
Up in the morning, head over to Virginia.
Don't plug my computer
Okay.
into that screen, I'll push the wrong
Nice.
button.
Maybe work in a haircut.
Maybe watch
There you
some
go.
YouTube videos
Yeah.
on how to do a victory
Oh,
roll.
my goodness.
That's always handy to do while you're out.
Well, yeah, I mean,
Yeah.
that's the thing about this
Yeah.
traveling. You know, you get
I
your
know.
car looked at or whatever.
Yeah, you try to fit in.
Get
it.
it all fit in.
Yeah.
Technical difficulties?
Do you want me to distract the audience until you figure it out?
What does Anita do?
Oh, I like that.
Yeah.
WDAD. Wada. What does Anita do?
Oh, already, yeah, the letters, wada. Wadad, wadad?
It's moving on this side.
Yeah, government.
Wadu?
Sarah, the mouse is moving on this side.
Yeah, it just won't, like when you click on stuff, it doesn't do anything.
So this is,
Weird, like it's- You can't minimize it or anything.
Do you exit out of the program and go back in?
I'll try.
You'll turn it off and turn it back on track.
Yeah.
Try to-
Yes, several times until it does it.
Haven't unplugged it yet.
Till it does what you want. Before you hand it to somebody else.
Most of this is all from the highway
This-
department,
Yeah.
so it's already been.
Let's try to do something.
it's gonna shut down for updates.
Yeah.
That's my favorite.
What is this?
And then it says 7% complete for 2 hours.
Oh. That's probably why, I know.
We are witnessing teamwork.
All right.
No big deal, and I didn't want to start because Sarah takes the minutes, so. So anyone
wanna-
who's watching us this morning, we are 3 minutes behind, but we had technical difficulties, and so we will start the Cook County Public Health and Human Services Board meeting at 6:34 a.m. today. And we will start with the approval of the consent agenda. Does anyone want to pull anything? Can I get a motion to approve?
I move to approve the consent agenda.
Support.
All in favor?
Aye.
Any opposed? Passes. In-home support program. Anita, go ahead and push the button.
Hi, I'm Anita Josiah, the program coordinator for the in-home support program. And what do I do here? I've been here for going on a year in October. And so the in-home support program comes under Minnesota Statute 245B. So of course there's always policy, procedure, and paperwork affiliated with that. And so just ensuring, trying to learn all the aspects of the 245D, which also includes some of Minnesota Statute 245A and Minnesota Rules 9554, and ensure that we're following all those policies and procedures. But it's providing services for people in our community, training, supporting, overseeing the people who go out and provide services to people in their homes. I mentioned on the screen there paperwork and lots of it, but I can't complain when I look at my coworkers. The other social workers have a lot more than I do, so I'm not, that one just goes along with being a licensed program. And then the service providers are independent contractors, so they submit their billing to me, and I review that, troubleshoot any concerns, pass it on to Martina, and then I think you eventually see it too. The final product. So what is in-home support? The bulk of what our people do is cleaning and organization, providing homemaker type of services for people in their homes to help them be able to stay in their homes. Some also need meal preparation assistance, and so that is an aspect that comes under the homemaking part. Also transportation, taking people to and from errands. We also have a medical transportation aspect to it, so sometimes our providers are taking people back and forth to Duluth or even the Twin Cities. Haven't had the Mayo yet, but that could even be a possibility. Companionship is an adult companionship piece, and personal support and respite care. And the bulk of our providers are at the $18.44 an hour is the wage that they receive for most of those services. But I guess I just want to mention it. There is a little bit of discrepancy depending on what they're doing. For adult companionship, that's a little bit less, and so is the personal support. And then respite care can be either daily wage or an hourly wage. So not me to mention them. If they're providing adult companionship, it's $15.04 an hour is what it comes to. Right now, there's one person who is doing that. He does provide some of the homemaking aspect of it, and so it's just a part of that, and so they have to split up, when they submit their billing, how that falls out. And then the respite care depends on a daily wage or hourly wage. We have one individual that does provide respite, and that's where there's a primary caregiver in the home. In this situation, the individual has severe dementia, and so it can be very draining on the person, and then if they need to go out of town for something, just have someone there that can manage the home while they're gone. Who qualifies for in-home support? Any Cook County resident or adult resident that has a permanent or temporary disability. I believe our youngest person is age 23. And then any Cook County resident who is at least 65 years old would qualify for services. And there are 3 different payment options. We have 22 people who are on the sliding fee scale. And that's for people, again, age 65 plus. The sliding fee scale is partially paid for by the county, and so the people with disabilities are not part of that. But if you're age 65 or older, you can apply for the sliding fee scale, and depending on your wage, you may pay $5 per month, $10 a month, $30 a month. They receive up to 5 hours of service. There's also private pay. Right now, we have individuals who do not qualify for the sliding fee scale and are not on a waiver, but they do pay privately, and so they will pay the individual providers $20 to $25 an hour. That was determined between them and their provider, you know, we kind of assisting with that. And we have 7 service recipients who are utilizing just the private pay option, and then 2 of those that are on the sliding fee scale feel a need for more than 5 hours a month, and so they do out-of-pocket pay for some additional services at the private pay level. We also have 12 recipients who are on waivers, and the waivers are to help people stay in their homes who otherwise would require nursing facility care. So there's different waivers. We don't have anyone on the brain injury waiver right now. We do have 8 people on the elderly waiver, 3 people on the caddy waiver, and 1 on the alternative care waiver. And we don't have anyone on the developmental disability waiver at this time. And so this was when I was still partially in process of developing the presentation, so it was actually as of yesterday, not as of May 8th of 17. This is what I had emailed Martina when it's still in the proofing part of it, and was looking at last year's numbers. But right now, as far as location of service providers and service recipients, we have 6 service recipients who are on the east end of the county, 3 on the west end, and 33 in Grand Marais. The east end providers actually, I would kind of say 2.5. One of our providers is on Highway 14, and we have that are fully on the east end. We don't have any on the west end right now, and then 9 who live in Grand Marais. I should mention, as far as wages, also there's an element of mileage reimbursement. If a person has to travel more than 10 miles round trip to be able to provide services, they do get a mileage reimbursement aspect to that as well. Their goals, of course, are to help people stay home and be safe in their homes, to have as much independence as possible, and also connection and support within the community. Some current challenges and gratifications. Challenges, it's always a challenge to kind of balance the number of service providers and service recipients to keep the providers with the number of hours they want, and to have enough providers to provide the services for our recipients. And right now it's a challenge because we had a service provider who had 9 clients who suddenly had not applied but was offered a full-time position at the school, and the week before school started. And so she accepted that position and gave us immediately 8 of her 9 service recipients. And so it's been a juggling act, getting services provided for them, and another service provider who's going to be going out on medical leave for 6 weeks. So if you've seen our current ads looking for providers, we definitely have a need. We have an upcoming Department of Human Services audit that is scheduled for October 10th, so we're trying to get ready for that in the midst of trying to make sure everybody's needs are met. And then service provider training is a little bit of a challenge. It's not in the aspect of that there's materials there that are available for doing wonderful, wonderful training for our providers. Unfortunately, with the reimbursements that we receive, there's no funding for their training. So they do all of their training. It's provided for free, but they don't receive any reimbursement for the training, and they're required to have 12 hours a year of mandatory training. There are 2 providers who have been with us a longer time, and as a result, they're only required to do 6 hours a year. And yet, when I put together the training and came to 8.6, or at least the combination I did to try and make sure that all the mandatory requirements were met for this year. So those are my challenges. Some gratifications. Both service recipients and providers are so pleased and happy with the program. I quoted one person there, service provider, said, "My life has been both touched and enriched by the people I serve." Other comments such as, "It allows me to meet and work with people from many walks of life, many of whom I may not have gotten to know otherwise. Working in Cook County's in-home support program has helped me to expand my horizons. I've found this work in home services extremely satisfying. You're meeting needs that, if left undone, might be detrimental to that individual. It's coming alongside them to lift them up, spirit, soul, and body." So that's it. What's really neat. They may be going into people's homes and providing primarily homemaking services, but there's that personal interaction there and that kind of radar to make sure those persons' needs are being met and addressing those in any way they can in the role that they're in, you know, and bringing things to my attention or the person's case manager's attention when they notice things. And service providers, I really appreciate all in-home support does. Just tons of praise and appreciation for all of our providers. Heidi's been such a blessing, and that's a miracle worker. Meredith is very efficient. I like that Renee washes my floor on her hands and knees. Roger's such a nice guy. Tim is so good for me. I couldn't live without Amanda. It's just very gratifying in those aspects. And thank you for allowing me to be here today. Any questions? I kind of flew through everything.
Jerry?
I'm wondering about where we're at now with this group of state services that were offered a year or so ago, and there was reimbursement, but we've tried to find a way to provide them. Is that still, are there still some services that we are not able to take advantage of?
To be fair to Martina, because I don't know them.
Yes, we have not been able to take those on. Care Partners was looking at possibly taking on in-home support program and those additional services, and they were not also able to do so. They didn't find that it was feasible for them to do so. We do have, for a long period, there was not a home health aide on staff with home care, and now they do have someone on staff, and so needs are being met that way with home health aide services. That was one piece that we were talking about taking on at one point, because we do have we are allowed to do so under the 245B license. We just
Right.
haven't had the time yet to put that into place.
Okay. Mhm. And I'm wondering too, how does this interface with an individual that might need nursing services along with the in-home support?
There are a number of individuals who receive in-home support who also have a home care nurse that comes out regularly and meets with them. And occasionally the aide assistant too.
So it's a working together
Yeah.
between the two. Okay. Mhm.
Yeah, and we will, communicate from time to time too to ensure that people's overall needs are being met.
I think a lot of times the providers and the nurses are probably seeing each other and communicating more than
Yeah.
they are with Anita, just because they're out in the field and they're
Mhm.
coming and going at similar times. So they have good relationships.
Are we still looking to find another provider that might provide these additional services that are you're not able to do right now?
I think we'd have to do some restructuring of the program to prepare for that. So it's not something that we've been focusing on right now, maybe in the future. But as it is, Anita's 30 hours a week and she is busy.
Yeah, I bet.
She's constantly trying to recruit new providers because there's turnover in this line of work. And then she's constantly getting referrals. So we're really, fairly new into her work as a coordinator for this program. She's done wonderful work. But it's even a year in and she's still very busy.
Yep, sounds like a vital program for us to have in Cook County. Thank you.
Any other questions, Jan?
Thank you, Madam Chair. Yes, and as we all face staff shortages, because I would imagine there's more need for the services than there are staff, and that I can see tipping in the near future, and I'm wondering what we can do, what we can do about that. I mean, obviously, I think fair wage is critical to that piece, so that we can compete in the marketplace for those people. Yeah, what can we do for that dilemma or that challenge that is coming down the pike? I guess, just a question. So are you seeing that yet? I mean, you're spending a fair amount of time recruiting. You're not seeing an end to. You've been able to fill all the positions so far.
Well, right now we have a need.
Okay.
Until recently, it's been kind of keeping up. When a need came, it seemed like I had, since I've been on just under a year, a good provider came along and got them hired and rolling. But right now, with especially the one provider that just left, and then also the one that's going to be on leave for 6 weeks, she has 9 clients as well. And then the new girls that are coming in from time to time. So right now, it's kind of the heaviest it has been for me since I've been in the position as far as trying to keep up.
The challenge is that many of these people receive 2 to 3 hours or less of in-home support services a month.
Right.
Or a week, sorry. So the provider is trying to build up their hours, and so they end up taking on 8 or 9 clients, and then if something happens, like
someone goes into the care center or moves or.
Yeah, it's a moving target.
They move the client, so their hours go down, and then it's kind of juggling act sometimes.
And if something happens to the provider, they get a new job, or they have a health emergency or whatever, and then we're kind of scrambling to try to find coverage.
Yeah, to keep that consistent weekly. And then the other challenge is having new people. As a service, the customer is having to build relationships with new people regularly, too, which can be a challenge as well. So, wow, that's good work for the work you've done so far, and really want to support you in the future, particularly knowing the challenges that are coming down.
Thank you.
Carla?
Well, I think Jan covered a lot about what I was asking, but you must at times have a wait list of clients, don't you?
Well, right now we have a couple people that are pending, and one of the individuals that had, the person who got the position at the school, have been able to find someone to either say, yes, I'll step in temporarily till you get someone hired, or yes, I'll take on another person, except for one individual that's going without. Right now, that's just within the last week or 2, but so far that hasn't been an issue since I've been here.
And the providers must have to travel, some of them quite a bit, to these different, except for the
like
Grand
right now we
Marais.
do have a couple of recipients on west end of the county, but the closest provider was in Grand Marais. So, and of course, they were on the caseload of the person who is going on leave. But yeah, so that's where that mileage reimbursement does help, because if they do have to travel more than 10 miles round trip to provide services, they receive an additional 54 cents a mile for those additional miles.
Well, it's amazing.
Jeannie?
Thank you. So when you get a referral, do you go out and interview and decide if it's going to fit with your program?
I haven't found anybody that hasn't been a fit, but I do usually talk a little bit by phone and explain the program and kind of thing, and then go out and meet with them. And there again, that's where some of that paperwork comes in. There's a number of forms for licensure that they have to sign, such as their service recipient rights and data privacy and application and all of that. So I try to get to know the individual and then also to match them with a provider that's a good fit for them. Because on occasion there's just personality here. And there too sometimes.
It's tricky.
For trying to figure out the right balance. Someone has to get a new provider just because it wasn't a right fit.
Are the providers mostly women, or do you have, depending upon the situation, men step in?
Out of the 12, we have 2 men.
Okay. Thank
And
you.
they're great, we love them.
Great.
Any other questions?
Yeah, well, go ahead,
Robbie?
Bob. Well, thanks so much for what you do. It's very important. We take care of our people that need it, and also you, Martina, for supervising it. And, this question is on revenue and so forth, and I understand that this is funded by the Arrowhead Economic Opportunity Agency, and not at all. This is state. Okay. So what's the reimbursement and our cost?
Some county dollars that go towards the sliding fee scale that we have in our budget. And that rate is $4.61 per 15-minute unit, or $18.44 per hour. And then we have 2 clients who receive their funding through an adult mental health initiative grant that our agency gets in. And then the waivers that Anita talked about, those are state funds. So those are people who are eligible for medical assistance and they meet nursing facility level of care, and we're trying to keep them in the community. So we put them on a waiver, and that pays for their community services, and that pays for this program. So, and then private pay.
And that's where the wage amount comes from, right? Is what we get reimbursed by through the waivers.
Yes, and sorry, I didn't answer that question. So the reimbursement from the state is exactly what we pay the providers. So we're not getting any
Administrative fee.
additional- We're paying them the $18.44 an hour, which is what the state reimburses.
So we're getting most of the reimbursement from the state.
You want to go back to that screen?
Right there.
The 12 recipients are waiver funded.
Okay.
And typically, so with the sliding fee scale, we limit that to 5 hours a month. Waivers, they have a larger budget, and that's the state funds, and so those recipients are getting.
Some up to around 20 hours a month, depending on their needs and how the case managers work real closely with them, which one they want their needs on.
So the bulk are sliding fee scale, but that's just at the 5 hours a month for each of those 21, or you said 22 people?
21.
21. And then there's the 12 that are on the waivers, and 7 that are private pay. Plus.
Right, and then the 2, forgot to mention before, using adult mental health funds. So.
Thank you.
Yeah, I was looking at your numbers, like 42 people. It seems kind of, hate to say it, like a low number. Do you think people in the county are aware that this is available to them?
We're in the process of putting out some advertising on that too. I'm not sure where that's in process. Most of the recipients come through referrals, and I haven't pushed really hard to advertise on that part right now because of I want to have providers
Right.
meet the needs. But it's ranged from about low 40s to low 50s in the year.
It's been interesting over the years because I used to coordinate this program. It kind of hovers around that amount because just as we're getting people in, there's people moving into the nursing home or people pass away, or they move out of county. So it's like this ever revolving door where we never get probably as many people as we could because they're coming in and they're going out. We get a lot of referrals from all of our county partners, so I think people are well aware, but we are trying to advertise more as well.
Any other questions? Thank you so much for all of the work and the presentation. Director's report.
Thank you.
Thank you, Anita and Martina, for your great report and for your work. Really nice to hear the statements from providers and clients about how this program's impacted their life. So thank you for sharing that.
We're thankful for the board's support too. Really thankful that this position was split out last year and allowed to have one position that focuses solely on the program. Thank you.
Good morning.
Good morning.
With our change in August schedules, it feels like I was just here. Happy to share a few updates from the department. In terms of staff updates, the public health coordinator position remains open. That will be open until filled. We did receive our first round of eligible applicants that were referred to us from the merit system last week. We reviewed the applications. I mentioned last month that we are accepting applications from a range of qualified candidates for this position, from a health educator to a registered nurse to a public health nurse. And we did receive qualified applicants within each of those qualifications. We are in the process of reaching out for interviews, and we'll be conducting interviews next week on that first round of applicants.
How many applicants?
We had 16 applicants,
Nice.
which
That
was
is
Look at that smile over
Yeah.
Yeah.
a lot more than we expected. There is a condition to that the way the merit system works is that they refer all eligible applicants who meet the minimum qualifications and indicate interest in Cook County. Some people we find click every county in the state, and some of the applications were, up to just under a year old. So the merit system will hold on to an application and continue to refer those through the statewide register to any vacancy within the state, as long as that applicant has indicated
Got it.
that particular county as an area of interest. So I'd say over half of the 16 were ones who didn't apply specifically for this posting. We did receive a number of applicants who were specifically interested in Cook County, as indicated by their application date, their cover letter. So we are very optimistic about moving forward.
The other 8, once we just get them across the county line, they won't want to leave.
People know where that is.
Yes. It's beautiful here.
And we did have many more applicants who met the health educator criteria as well. That's a bachelor's with experience as opposed to the licensed positions. But again, we did have applicants within each of those.
Awesome.
And as I said, that posting will remain open until filled, until we have a name to present the board. That could be as early as October.
Awesome.
Updates from the agency as a whole. We hosted a child care and foster care provider information session yesterday evening at the community center. PHHS licensor Heidi Akins was available. She had applications for both family foster care and child care available, and was just providing general information about how to become licensed. There were several current and prospective child care and foster care providers in attendance. Several applications were given out for foster care, and I think one for child care. Pat Campanero from the Small Business Development Council was there to provide more of the business end of support, which is really outside of our scope as an agency, so we're thankful to have her there, as well as Wendy Hansen, who has a new role as a regional support person for child care providers through the Center for Inclusive Child Care. So she was also there to be a support and to make connections with current and prospective providers. This month, we are recognizing Emergency Preparedness Month, as well as Healthy Aging Month. So you'll see on the bulletin boards in the courthouse, up at the clinic, and in our lobby, we have information on preparedness. We have this really nice personal emergency kit available. It's posted on Facebook and again in the lobbies here. And we're sharing information throughout the month on preparedness and healthy aging programs like in-home support through our Facebook page throughout the month.
And we have really cool bags to put your emergency kit in.
Yeah.
We do, and the number one item that people forget when they need to leave their home quickly is your connections to your phone, to your computer, to those types of equipment pieces, and those are just good reminders, because when emergency situations come up so quickly, and we know for us oftentimes it's fire-related or flood-related or power outage-related, that to have, like Allison showed, something that can help us think about those items is really helpful, because in stressful situations, it's so common just to forget. Mm-hmm. So those are pieces as you work in your various communities to be sharing with your constituents too, those important messages. So I always appreciate the opportunity just to bring a message to you that you can also help promote. So thank you for doing that.
See, when I leave town, I have 8 million power cords, and I forget my allergy medicine.
I guess you need a cord for that, Heidi. Yeah. But I think it's a great example that that's part of your routine. And even though it's part of your routine, sometimes we just forget.
Thank you.
Thank you, Joni.
Yeah.
Lastly, just want to give a brief update on our community health assessment.
Mm-hmm.
We met in August. That meeting, we had great attendance at that meeting, more so than any other of our stakeholder sessions thus far, and a few new faces as well, which is always fun to have new input into that group. That meeting was really devoted to developing our problem statements, which within each of the priority areas, digging deeper into the issue of behavioral health, so including mental health, substance abuse, and healthy living access. We're meeting again in October to really begin development of our community health improvement plan. And for those of you who have been involved thus far, if you're interested in becoming involved, just let us know. We have some tentative dates out there, and we'll be happy to share those with you. I'll move along to an update on the Public Health Community Fund Work Group. Just a brief history of that process. The Public Health and Human Services Advisory Committee was tasked last year with reviewing applications for the discretionary funds that were formerly in the general fund budget, and those that were determined to have a public health purpose as opposed to the arts and culture grants. Those were, as I said, the Public Health and Human Services Advisory Committee was tasked with reviewing the applications and then making recommendations to the board after that initial review. For the 2019 budget, Public Health and Human Services is acting as the grant manager, with Joni Christensen serving as the agency point of contact for those applications. Earlier this summer, we met with the advisory committee and reviewed the application materials, the scoring criteria, to try and align the application with some of the priorities of our community health needs assessment. How can we really target some of the needs that the community has identified as our top priorities? The applications were open, I believe it was the month of July. Mm-hmm. We received 13 applications for funds this year, including 6 new applicants. 7 of those who applied had applied for funding in the 2018 budget year. We used a ranking process. The committee reviewed each of the requests against the other to try and determine a consensus in that priority ranking. Once there was a consensus of priority ranking, we met again to determine how that $130,000 that were allocated would be distributed amongst those applicants. We had approximately $187,000 worth of requests, so we knew that we weren't going to be able to fund all of the requests. The decision was made by the group, and this was just last week, to fully fund the applicants that were top ranked, that received the highest number of priority votes, to deny funds to those who received the least amount of votes, and to apply a % reduction across the board to all others. Joni sent out initial notification just last week to all applicants to let them know the tentative amount, just so that they could move forward if needed with pursuing any additional funding sources for 2019.
I also sent letters to those who we were recommending not receive funding for 2019 as well. And so have had some good response back from both, recipients and non. Good comments, of course, about process and review and going forward. And one applicant who we're recommending for not receiving funding, just even with great questions about, and where else might I look for funding, and how else, and could you give direction even in how we could improve our writing of the grant process. So those are always great phone calls and emails to receive for both ways. And again, I really appreciate the board passing this responsibility on to our department. I think it really, like Allison said, really blends well with our community needs assessment and priority areas. And as a first time absorbing it into our department, I'm excited with where we will even go forward. So those would just be a few comments back on that process for myself.
I am so grateful that you have taken it on and that you're doing it. And it still needs final budget and board approval, but my biggest frustration was the line item cut on December 18th, and you have all these applicants who then miss other opportunities to get funding. So the fact that you've already reached out to them in September to let them know that they can find other sources is just wonderful for them and for us. So thank you so much for the work on that.
It hasn't been an easy process, we know.
It never is.
They're all really valid requests, all doing great work in the community that supports our mission as well. But again, really thankful for the time and energy that the work group has put into really reviewing these applications intentionally and offering Joni and I feedback going forward for how to really strengthen and improve this process going forward.
What was hard and frustrating as a commissioner, because you say, oh, well, this group is asking for 80 and we'll give them 40, and we as commissioners had no idea what the impact on your department would be to do that. So thank you.
I think it introduced an element of a rational process to this, and it brought in, as members of the advisory committee, brought in additional people to review it more closely and come up with recommendations that had some, backing in terms of the input we knew from advisory committee standpoint.
Thank you so much.
And just the strength of our work group members. So really diverse experiences working with grant management, and just so thankful for the expertise that they've brought to this process as well. Anything else, Jerry or Carla, that you want to add to that? Okay.
That's it?
That's it for me, unless there are any questions.
Any questions at all? All right. So let's talk about opioids. The commissioners received an update from AMC that said there were 150 people involved in the opioid summit that I went to for the Association of Minnesota Counties. The registration has 137 that we had before we went, so this is across the state. It was an invitation to commissioners, public health staff, law enforcement, I believe, and other agencies. It was a full day from 9 a.m. to 5 p.m. Lots and lots and lots and lots of statistics and numbers and work group sessions, and I believe I was the only one from Cook County, and then Board Chair Rich Svay from Lake County was there, and we both walked out at 5 o'clock not knowing what to do moving forward. And what do we take with it, because there wasn't time to spend on steps. So I met with Allison yesterday and Greg from our Wilderness Outreach and Grace, who work on this, just to see what we're doing here in Cook County, and obviously we're doing a lot in Cook County and covering it, so I don't want to scare people with numbers and statistics and have people think something's coming here to Cook County and we have to close the gates. One of the things they started out with is on opioids, the U.S. consumes 80% of the world's opioids. I know, you hear that at the start of the conference and you go, holy moly. Some of the statistics they had for us is their records from 2000. There were 10,000 deaths related to opioids just in the U.S. From 2000 to 2010, in that 10-year period, it doubled to 20,000 deaths. But then it doubled again in just 6 years. In 2016, the number was 40,000. And then within 1 year, the deaths were 50,000 from opioid use. So it's going fast, and a lot of that is related to the fentanyl that's getting added into it. And fentanyl-only deaths for 2016 were 30,000. So you've got 30,000 fentanyl deaths and 40,000 opioid deaths written down. The part where I went into a panic is St. Louis County, which is very close to us. A lot of us think this is a metro issue, and it's not a metro issue. St. Louis County developed the state's first medically monitored opioid withdrawal unit that opened January 1st of this year, and they've already served 88 clients in St. Louis County. They said that it disproportionately affects American Indians. We have the highest numbers. Part of the issues that we're facing is stigma and education. And what is opioid? Is it a prescription addiction? Is it more than a prescription addiction? You know, how is it hitting us? In the metro area, they are increasing security in libraries because it is the easiest place for people to get and use their opioids. It's free to be in the library, to hang out in the library. That was an interesting thing to find out that counties around the state have had to address that. We go into our library and everyone's on their computers and working. They're using the Wi-Fi. So one of the things they said is you can't arrest your way out of the addiction, that we have to start looking at it differently. And then the other effect on public health and human services in counties is out-of-home placements. If you have one or both parents addicted, and the conversation during the day changed from opioids to the full spectrum of addictions and how this is affecting counties. One of the presenters claimed that marijuana is the gateway drug, and all of us have heard this at different sessions that we've been into.
So people are still believing that, or?
That was one presenter's opinion. One really cool thing they did during the session is they had, I think it was 8 presenters. It was called the lightning round. So here's all the presenters on the lightning round if you want information on it. And they got 8 minutes, and they had to get up and tell us what their problem was, what their issue in their community was, and what they were doing to resolve it. So they've got a logic model. Anoka County has the Chemical Health and Heroin Initiative. So there's all of this data if anyone wants to look at it with me. I do have, from the General Committee, we had an update on out-of-home placements for 2015, but we didn't have time to discuss in the Opioid Summit or the General Committee how this may or may not be attached to the addiction issue, whether or not those out-of-home placements correlate with each other or not. And then one county has these lovely bags, and this is the opioid crisis in farm country. So you can put 45 tablets in this bag with this pack and dissolve them. Now, for us environmentalists up here, these single-use bags, you know, they take 10,000 years to disintegrate, so I don't know if this is the appropriate way to dispose of your pills. I will tell you that the bags are not chocolate lab proof, but the lab does not want to eat the reactor. My chocolate lab tested them for you. I do have bags if anyone wants to try these out at all.
Agreed.
I grabbed a few for us. I don't know if our recycle center will take the bags or what you do with them. They said you could just put them in your garbage afterwards.
I'm confused. What is the bag for?
So let's say you get a prescription, that's
Yeah.
an opioid, and we have drop boxes and prescription
Right,
days. So if you don't have drop box days or prescription days, you take this package, put this in, add water, put your tablets in.
So you
and get
dissolve
rid of
them,
Yes, because one of the things they talked about
but
is
then they
when
go into the water
they go in the
system.
garbage. They said you can put it right in the garbage.
Oh, they don't go in the water system because they're
No.
dissolved in this bag,
They dissolve in the bag and then go right in the garbage.
which then goes into the.
But they said if you have
water
an
table
addict in your
eventually.
family and you've got someone on long-term care that has been using opioids, the addict in the family will know, and when you have your open house for the funeral, they know to go into the person who's died and take their prescriptions. So that was, I know, we learned all this, I know, I'm sitting during the whole meeting doing what you're doing, I'm like, what? So.
It's an addiction.
It's an addiction.
It's a serious
and-
addiction.
And it's a stigma, and it goes along with the mental health stigma, and how do the two work together. And so we got tons and tons of information. I have stuff if you have questions, but we didn't leave with any answers or resolutions or tools that we can take back. But I think a huge awareness of how big the issue is, and that it's a statewide issue, and that it is happening everywhere. And how do we stay ahead of it? So that was what I took away from it. And then I met with the staff yesterday and feel much better that there's no big train coming here that's going to derail us. And
No, we're
We're on top of
humans.
it.
We are.
have a lot of resources that other counties don't have. We're really lucky to have Greg. So, and our law enforcement and Deputy Eddie.
Oh, Eddie, yeah.
Eddie.
Yeah.
Are they
Eddie's
going to
taking care of it.
follow up with another summit on this next year or anything? or-
Be great.
So this is new to Association of Minnesota Counties. This is something the executive team, I guess you'd call it, has decided. They had asked commissioners, there's over 400 commissioners in the state, and they had asked, because we meet quarterly, if we did a day session the day before our scheduled meetings, would people actually show up? So the fact that 137 people signed up is great. That means they'll continue to do them. And like I had told Allison yesterday, I also sit on the Futures Task Force, which is an application-based group through the Association of Minnesota Counties. I call it Las Vegas because the rules are what happens here stays here. And it's the conversations that we have so that we can openly talk about our communities. But one of the sessions I was in within the last year talked about, we had people from the U of M in talking to us, and they found the part in the brain that if that is triggered, if you're an addictive personality, there's truly a part of the
Physical.
brain, and you don't know until you drink that alcohol or smoke that cigarette or have the marijuana. Once that's activated, you can't unteach it. And so they're talking about, can they manage that part of your brain to send a message that you're always being fed whatever keeps it going without actually having the addiction. So that was something we learned a long time ago, which I can't explain very well. Jeff's looking at me like, what? I asked if you could put a shunt in there, and that's kind of what they were talking about. It's a constant feed, like a pacemaker, that tells that part of your brain that you're being fed whatever it needs to.
There'll be a reaction to that, too. I mean, there will be. It's a,
Well, in our breakout session, there was a
Yeah.
group of people from housing that do housing for different levels of the community, and to get into some of this housing, you can't be an addict. And so they were fighting with some public health people in the meeting because they've started this clinic, and the treatment to get off of drugs is to take drugs. And you can't get approved for housing if you're using drugs. And so they're like, we can't house these people because you're constantly medicating them, and they don't have an end time, because for some people they will have to be medicated forever. So do you change the requirements for housing? Is that the next step, so that they can get into housing and be able to continue to be treated and have a quality of life?
yes, on all those fronts. The paradigm really needs to shift about this. It's,
Stigma.
Yeah, the idea of drug use, that old idea, is not this addiction. This is a
Well, the public
very
health staff
powerful.
finally blurted out and said, is anyone in your family on diabetes? Do you ask them when they'll be off medication?
Right.
And it was like, whoa, got a little heated in that room.
Yeah, and this is medication. This is powerful pain medication that,
And Greg had said that, it's coping. The usage
Mhm.
of whatever they're using is a coping. So what do you replace that coping with? And for some, it's the methadone or other treatment.
so with those statistics, I mean, when we say opioids, I don't really know what that means. Are they talking just prescription opioids, or are they talking heroin too?
Heroin was
and all
later
that.
in the discussion.
Okay.
Originally, it was just the opioids, and then it went across the board of all addictions. And they didn't give us statistics for all addictions, and I got
Okay.
a little annoyed because we had a presenter that came in from NACO, the National Association of Counties, and he said Pennsylvania like 5 times. And I'm like, you're in Minnesota, I need statistics for Minnesota. So, you know, they represent all states, so he looks at the largest issue and brings that to it, so, I don't know, I was a little worried when I walked out of there. Go ahead, Ginny.
Thank you. Just to follow up on your comment, is there future plans for more workshops and presentations? When I was at the conference, I attended the Health Policy Committee, and so what we do there is we come up with 3 different resolutions that we're going to discuss at our next meeting, which is called a district meeting, and that's going to be in October. We have 3 resolutions, and then we also have platforms. And one of the platforms is opioid and narcotics. So I don't think it'll ever drop. You know, the way
What
everything's.
group is this that you're referring to?
This is, well, we were attending the Association of Counties last week,
Oh,
but
okay.
this is our district meeting next, which is the 11 counties that we participate together with. So that'll be brought up, both resolutions and then a platform to discuss other issues too, and one of them is out-of-home placement, which all goes with, you know, it all goes hand in hand. Yeah.
So Jerry, the Association of Minnesota Counties, we have 5 policy groups. So Ginny sits on the Health and Human Services Policy Group. So each policy group comes up with the platform, and the Association of Minnesota Counties moves forward with the state and our legislators. So instead of having 87 different counties with 5 to 7 commissioners, all with their own and personal agendas going to the state, we have one solid voice. So there's a better chance
Good.
of movement on the topics.
Yeah.
And so we pick them in September. Not all commissioners can make it to the September meeting, so then it goes to each district meeting. There's 10 districts in the state. And then they vote on them. And then when we meet again in December with the full Association of Minnesota Counties, we vote again. It's a
Good.
huge, long process.
Good to hear, though.
Yeah.
Thank you.
And then it goes to the
It's very
legislatures in
strategic.
January.
Yeah, great.
So
Yeah.
it's a step process, but it all works because we're all working together on coming up with things that affect all of us in the
You bet.
state.
Yeah.
Yeah.
And then it's also an opportunity to have excellent educational seminars. And seriously, that had to have been just an excellent educational seminar.
Yeah. It was a lot of information.
Always been impressed with AMC seminars. They're amazing.
Yeah.
It's a very, very great group.
And we can always request, you know, Rich and I might approach, and Rich is on the board, so we might approach them and say, can we have a phase 2 to this? Can we have practices or how to move forward or tactics to bring back to communities? Because he walked out of there just like me going, wow, that's a lot of
It would seem like the needs of smaller or rural counties are different, and some extra guidance are being developed on how does a county like ours put in place some tangible ways of responding would be pretty helpful.
Yeah, we were sitting there at breakfast on Thursday morning. I was sitting with Pipestone commissioners, and they were talking about whether or not they were going to make it through Friday because they had, in the town of Island, just down southern Minnesota, they had a drug-related shooting with their law enforcement that morning. So it's just a little tiny rural community, and so it's all about resources, and I am really glad we have the resources we have and the people we have in place.
Yeah.
It just seems to me that as we learn more about the complexity of it,
Yeah.
there needs to be so much education to the public, to physicians, to pharmaceuticals.
Yep.
Research maybe in non-addictive painkillers, and, you know.
Mhm.
Because I've commented here before, Don had had a number of experiences where he didn't need it, and he's sent home with like 90 pills.
Right.
And they
Mhm.
go right to the sheriff. And I had my first hospitalization, a wonderful physician that agreed and only put it down if I needed it. But I had some very aggressive nurses that came in constantly waking me up all the time. What's your pain level? 3. Well, don't you want to take this? I said, no. I mean, it was a constant
Wow.
fight. And so
Yeah.
Right.
we
Yeah,
got a
the-
survey from them, and I just
Yeah.
put that in there. I appreciated that he was not going to send me home
Yeah.
with anything.
That was the discussion we had when I was at Futures at the earlier meeting was, originally, doctors were told way back when that this is the easiest, safest way to control pain. Like, that was your thing, is to control pain with medication, and now they're
It's
relearning.
very powerful. It's
Yeah, I
very
mean, there was
powerful.
one county that came in and they found that their pharmacies were processing 100,000 opioid tablets a month. And so they went and they had groups come together, and they had hospital, clinic, pharmacies all sit down, and they're like, we can't continue this. And so they got it down to 20,000 tablets a month, and I can't remember which community was able to do that, to come with another source of prescriptions.
I would just like to mention too that, you know, we're a small county, but we have some real good assets. Last night at our YMCA Advisory Council meeting, excuse me, we were starting our strategic planning process, and we went through, you know, what's going well, what could we do better, what's working, but we need to give more attention to it, and some things that are problematic. But I know that one of the things we did last year that we're reviewing with very positive results is this, we call it a generation room. And so there was this room you see when you walk into the building, and we put games in there, and we put in some suitable kind of you know, activities that we could monitor, especially on the computers and so forth. But you know, we have up to 12 kids that come in there, and those kids would be out in the street more than likely. And I don't want to stigmatize anyone or anything like that, but these are kids that need a place to be. And when we can swim upstream, you know, that's, from my background, at least in education and psychology, is that where we got to put our efforts. We've got to be preventative. And so we have a tremendous asset there in the community, and we're trying to deal with it, because one of the biggest things about YUSA and our Y here is healthy living. Well, drug use is not part of healthy living, and having a place for people to go, but also to have caring adults around, and they see things and can get on top of things, so you're getting that preventative measure as well. And so I wasn't able to stay for the whole session, but I know that there was quite a few post-it notes there indicating that we're really making a difference in some kids' lives, and that's where we should be, you know, preventative. Yeah.
But I just, you said drug use is not part of healthy living, and I think we sort of need to change our attitude about that, because drug use is vast, and if you're in chronic pain, I think probably some drug use is probably needed for healthy living. So it's a complex, when it comes to drugs, it's a complex issue, which I think is what we're discovering with opioids.
But for most children,
But
they
an
don't-
alternative for kids, when it's not about a chronic pain issue, you know, when it's recreational, that's great to have other recreational activities, alternatives for people to participate in, absolutely. But not all opioid use is, probably a lot of it is not recreational. A lot of it is come from a chronic pain issue and coping with painful.
Yeah, they say that it's 20% of people have this susceptibility, and if they're on opioids, hydrocodone or any of those, for more than, I can't remember the exact number, but I think it's something like 11 days, those 20 people are going to get hooked. So we got to, get some alternative.
Well, the people that were at our meeting said it's one time. It's not even 11 days. For
Well,
some, it's
that's not what I
once
read
the
in
trigger.
in the journals, but and so I know that I have chronic pain, and I don't take drugs for it, I have to find other ways to deal with that. And I know that where I do my, work, I see specialists in orthopedics and pain center, and, they're not just going that route. So I think the medical community, unfortunately, reacted a little late, but they're reacting.
Thank you for your comments, Jan. My sister would be in an institution if she didn't have strong medication since the day she was born.
Yeah.
And so,
A lot of us need drugs.
yeah. So, any other questions on the summit? I don't want to see any more drug questions today. All right, we will move on to committee reports. Arrowhead Economic Opportunity.
We're having our, I mentioned last time that I missed the meeting in August, but we're having our annual meeting in October, and I plan to go. It's working on the schedule so far.
Okay, great. Jan, Arrowhead Health Alliance.
Thank you, Madam Chair. I was unable to go. You were unable to go, but Allison, I believe, attended
She went for
via
us.
video. Yes.
How'd it go, Allison?
It went well. It was okay. Attended by video and had some difficulty hearing, but the group was accommodating and let me call in. I think there was an issue with the microphone placement, but just a few updates from that group. There was discussion about some plumbing issues at the Birch Tree Center and how to address those. They're being very planful about how to address the plumbing issues while minimizing the impact on patients at the facility. So that's in the works.
That's a new facility.
It is, yeah.
Okay.
They reported an increase in crisis line utilization at Birch Tree Center, which of course is a good thing and a bad thing. Of course, people are getting help, and it might indicate that some of the outreach is having an impact, that people are getting the information on the crisis services that are available in the region. A contract was approved at the meeting to move forward with consulting services for the Regional Behavioral Health Crisis Center. They also shared some photos and an update on the Mental Health Day at the fair. It was the first annual. Reported it was a great success, really great exposure for behavioral health and telehealth. In particular, they had demonstrations with people within Region 3, the Arrowhead region, who are connecting to St. Paul via video. So a nice way to introduce that to fairgoers. And Grace from PHHS attended that as well. So she was able to attend with support from the Region 3 Behavioral Health Initiative, Arrowhead Behavioral Health Initiative. The Arrowhead Health Alliance is also coordinating a telepresence effort to connect regional mental health providers and Breakwater, which is a group of federally qualified community health centers, including the Sawtooth Mountain Clinic. And they received a grant and support through the U of M. So how this was summarized at the meeting was that it really strengthens the existing network that we have in the region with some funds and then data reporting capabilities through the grant. They have to report out, so that will really give the region the data to show what an impact the service is having for rural areas.
Thank you. And yes, since we just met a couple weeks ago, a lot of these will be saying we haven't met yet, which is mine on Community Health Board. Public Health and Human Service Advisory Committee.
We had our roundtable, as you know, where we go around, and North Shore Healthcare Foundation is zeroing in on 3 key issues to direct their funding, and they found having participation in the community health needs assessment was critical in helping guide them. Another thing is, as you know, Dr. Stover's leaving, and they're having a reception for her on September 25th from 4:30 to 6:30. And she will stop seeing patients on the 22nd, and work paperwork through the month. Dr. Catherine Hansen is joining the staff on October 1st, and they feel she'll be a very good fit, for up here. MnDOT is going to continue construction for 2 more summers, which you probably know, on 61. And Steve Nielsen mentioned the hospital board was considering the levy, and I heard on TIP they did approve a levy on the 13th that they're going to do. He also mentioned he has a friend who's just coming up, I think, for a visit, but he had worked in assisted living for a long time, and he has set up very small units of maybe 10 to 12 beds. And so he was just going to kind of brainstorm with Steve when he came up. Pat Campanero is offering free assistance to anyone wanting to start up a business, and that was evident in your daycare foster care meeting, that she could help them with that side of it. The HDC got their SLIMS grant for schoolwork again, so that's a good thing. Let's see what else happened here. The community, the public health is pushing people to be more aware of the need to do well water testing, especially if there are infants in their home. And the Y is going to continue with their course for pre-diabetic people. Now, anyone can take it, but the clinic is offering a free scholarship. The cost is $100 a year to anyone, regardless of income, if they are diagnosed as pre-diabetic. And people say it's an excellent program to be in. But again, you can only get the scholarship if you're really diagnosed that way, but anyone could benefit just from attending it. And I think those were the highlights of that part.
Okay, I've got a few other items from a little farther down in the agenda. We learned, and might have been from you, Allison, of some federal grant money available for additional CD services for next year.
Yes, so I shared with the advisory committee, similar to my budget presentation last month, about the substance use disorder reforms that were approved by the Center for Medicaid and Medicare Services for the state of Minnesota to implement additional services to support people in treatment and recovery. So that those are the services that we're exploring how we could implement those as an agency. A part of that would be bringing on an additional support staff person to take on those roles.
Great. Mm-hmm.
Thank
you. There was a meeting at the hospital to explore healthy communities or mental health needs in the community. I wasn't able to attend that, but learned that the sort of the statement put out by that group was in reference to create healthy communities where there is no stigma to mental health services, and that emphasis certainly dovetails well with what we're working on in our community health needs assessment process. And we had talked several months ago, or maybe it was last year sometime, about taking a look at the county's tobacco ordinance and with specific reference to e-cigarettes. Mm-hmm. And that's still, we're going to, Joni was saying she's going to make a point of coming back with some more on that, possibly a draft of ordinance changes relative to that before she finishes up in December. So we're looking forward to that.
Great. I did go to the mental health at the hospital, and hopefully there will be more sessions to carry on from that. It was on the 28th, so we had this meeting that morning, so I missed the first half. But there was probably 40 people from the community in there. There was Grand Portage, one of the hospital board members. I was there. Your staff?
Joni was there.
Joni was there. Sherry Moe was there for a little bit. And
Martina also was there.
Martina was there. So yeah, we talked about stigma and making it okay, and then putting out ideas and breaking into groups and things we can do as a community. So I'm hoping that we meet again and can actually put some items into action or figure out how to move forward and do some action items. I did tell them that I regularly during meetings talk about my mental illness, so I'm doing my best to not have a stigma on it. I tell people all the time. It's just who we are as people, and a lot of things on the outside we all accept from people as they are, but you never know what's going on in someone's life or someone's head, and so it's time to make that a comfortable conversation that we all have.
Mhm.
And so I have no problem being the guinea pig on that. But it was a good session. It was a very long day. So the next one we have is Ginny, healthcare planning.
Yes, we had a get-together with a small group of people. Kimber was presenting the hospital board's upcoming decision on their levy, although it hadn't been solved by then, but now it's solved. So we had that, and then Kay from Care Partners provided a little brochure, and I guess it'll be around in the community, about just aging services in the county, so key providers, what's provided up in Grand Portage, other resources. So it's just a little, put-together booklet, and I'm not sure if she would be able to put it online, if she is even online with something like this. But anyway, it should be out in the community within another couple weeks.
Great, that's it, yeah, thank you. Jan, North Shore Collaborative?
Thank you, Madam Chair. They have not met this month.
Okay, emergency preparedness.
I think we're scheduled, or at least I have it on my calendar for next Tuesday, but I haven't gotten an agenda or anything yet, but I'm supposed to continue with some kind of training.
All right, anything else? Would anyone like to adjourn?
So moved. Go for it.
1, 2. All in favor?
Aye.
Excellent, thank you so much. You can take that if you want, or you don't have any. You said you don't use that stuff.
This is astounding. 74% of farmers in South are impacted by the epidemic.
Yeah, it's not a recreational deal.
Okay, well, it's already saying it's ready to go.
Okay.
Little preamp work.
74 pounds or something. Collection.
No, but I had just gotten an email that there's a new concoction with opioids and fentanyl called Pink, but